affordable, and a long-term use possible management had to be found out. So based on the limitations, the ideal drug had yet to be found. So what is this 7-MX? Basically, it is a oral adenosine receptor antagonist. It is a metabolite of caffeine, and it is a non-selective adenosine receptor antagonist, which was, how does it work? So it basically modulates the scleral remodeling and collagen synthesis. So it is basically working on the axial, decreasing the axial elongation. And in Denmark, it is approved since 2009. So in this paper, the preclinical evidences, clinical evidences, and how the drug effects are discussed. So first talking about the preclinical evidences. So the initial discovery was done on the animal model. So for the rabbit and the guinea pig, the experiments were done, and it was found that there is an increase in collagen content and fibrillar diameter of the sclera. Also, there is a potential strengthening of sclera, so reducing axial elongation. So for both of the animals, there was axial elongation which was retarded, and no side effects were reported. After the initial discovery, later on the higher species, so rhesus monkey and trichus were also been experimented. Before that, for the aves, it was chickens who were been experimented. But for that study, it was a very short, and along with that, no side effect reported. For the other animal models of rhesus monkey and trichus, of course, there were no side effects observed, but along with that, there was a reduced myopia which was being observed into these animals. So once the preclinical evidence was found to be okay, then the clinical trial was done. So the studies which reported about the clinical trial in Denmark, the initial study it was 77 children, and for them, a dosage of 400 mg of 7-MX was given. So a comparison of daily versus a placebo was given, and for 36 months this was being continued. So for this clinical trial study, they found that axial elongation was reduced. Also, they found that like for a 24-month extension, they continued the treatment group had a greater reduction versus the delayed group, and no rebound effect was found after stopping the dosage. So basically no side effect, and it was continued. So after this study, the next long-term study was done from 2000 to 2021. So based on the clinical evidences from this study, it was 711 children who were being given the doses, and they were followed up for a period of up to 9 years. So uh, at the end, they found that children who had moderate myopia at the baseline, they had a higher effect for this dosage. And also from this study, they found out that increasing the dosage would be giving a better decrease in the axial elongation. Also, based on this, there were the comparisons with the other available modalities. So because initially we discussed that there was a need of a new formulation or a better formulation as compared to the currently available dosages, currently available options for myopia management. So there was a comparable uh, decreased axial elongation with help of the other modalities also. So this is the comparison which is done with the MySight contact lenses. MySight is available from Cooper Vision. It is basically a center distance design, and the other comparison was with the 0.01 atropine. So similarly, there was a decrease in the axial elongation observed with the 7-MX also. But for atropine, there are reported evidences of side effects. 7-MX did not had number one side effects, and number two, there is no rebound which was being found for 7-MX. So how is the mechanism of action working? It basically blocks the adenosine receptors, and inhibits the scleral elongation. So there is decreased axial elongation, decreased progression of the myopia. Also, based on the earlier studies, the safety profile for this drug was checked and no adverse effects were reported for over 10 years. No gene toxic or mutagenic, and it was also safe in the animal studies. So, while preparing the slides, had a question that if 7-MX is a derivative of caffeine, why not the other uh, modalities, like why not the other caffeine derivatives could be working? So I searched out a few more studies related to this, and I have tried to sum it up with the comparative models. So if we talk about the derivatives, caffeine compared to theobromine, to theophylline and paraxanthine. So into that also there is the number one, paraxanthine is less studied. The other ones have systemic side effects, so toxicity could happen. Now, directly comparing caffeine to that of the 7-MX, then number one, caffeine has a short half-life. It has non-targeted actions, and there are reported side effects. But 7-MX, it is a selectively acting on the ocular tissue. Also, it has minimal CNS effects, and that is why it is more safe for the pediatric population as compared to the other caffeine and caffeine derivatives. So from this study, the limitations and the future directions, what we got is that till date, only the studies are reported from Denmark. So again, not seen on the other uh, population of the world. So a global multicentric RCT is yet to be understood. And uh, second is a sustained release formulation, because in the longitudinal study we saw that there was need of increasing in the dosage for decreasing the progression. So a sustained release formulations could be found out. And of course, the studies on the combination therapies are also not studied. But again, one of the study with respect to this article was showing that as compared to merging up atropine with that of other modalities, merging up 7-MX could work better because of the lesser systemic side effects. And thus, to conclude, 7-MX is safe, comparable in terms of efficacy, and suitable long-term use because of no rebound also. So, combination therapy could also be worked upon. Thank you.
Yeah, you can stop sharing. Yes. I think one of the major reasons why I wanted you to present on, or why I wanted to discuss 7-methyl-xanthine was because it has a completely, the reason why it is equally important as atropine is because it has a completely separate modality of action. So it is very easy that, you can combine it, and obviously it will have a symbiotic action, although it is not studied. I think Antod Pharma from India are working on drop formulation of 7-methyl-xanthine. And now the point is that it has to get absorbed and should reach to the sclera because it works on the modulation of collagen in sclera. So that was regarding 7-methyl-xanthine. The today's basic meeting is on atropine. I just wanted to talk about 7-methyl-xanthine because this is completely something which is not known to Indian people. Why it is not available in India? Because the API is exclusively in Europe and it is quite expensive since last 5-6 years, because this drug has been around now since almost 15 years since I knew about it. So it has been years since we have been telling pharma people, especially Antod and Sun Pharma, that these 7-methyl-xanthine is there, and you can always take out a tablet and you can definitely we can have this in our country, but it has not been available. So that was regarding 7-methyl-xanthine. We can open the meeting for questions on atropine. If there are any questions on the video that I had uploaded, please go ahead and ask. If you want, I can share the presentation of atropine, but it is the same which I had previously shared on YouTube.
Sir, I had a question.
Yes, sir.
Regarding the Atlas study, it was seen that most of the people who were in the treatment are eventually caught up with the myopia progression. So, what is the thought process about rebound and when and for stopping of the treatment, or when do you start to taper actually? Seeing that
Actually,
these
you
studies have come up
see,
now.
bulk of the discussion, argument, and thought process is on the fact that when to stop atropine. Now, I will. Your question has multiple questions. The first question is whether if Atlas study says that eventually everybody caught up, whether it is worthwhile to put atropine. So that is question number one. Question number two is that was it because of rebound or was it because of the fact that they stopped atropine before the actual myopia effect was still going on and they stopped atropine midway? Now, the first question is answerable by second question, and both the questions are answerable by LAMP. Actually, LAMP study, LAMP 1 and LAMP 2 are the bulk of the studies which are studied. And unfortunately, after LAMP 2, nobody went forward and saw their work. I will share the slides and I will answer this question of yours. So I will share, yeah, this is, and you can stop me midway also. So basically this is what we saw from LAMP. They tried to do a placebo controlled trial. This was the first phase. This was published in 2019. Now basically what they are trying to say is that 0.05% is the best concentration. There is nothing else in this particular part 1. We already know that this is the comparison. I told you about the comparison. This is the amount of axial length change. This is the amount of this thing. Just one point here, that if you see placebo versus atropine, they did not find any significant difference. Yes, with 0.05, they found a significant difference, but this particular 0.2 millimeter difference was not corroborating with the amount of mean change in spherical equivalent. So that point we have to remember, and we will move on to the next point. The take-home message obviously was that 0.05% is the best. So that's the whole takeaway message of phase 1. Phase 2, again, bulk of the work was that whether for 2 years it holds the what they had said for phase 1, because myopia is a long-term disease and we have to see for at least 2 years, and because atom was for 2 years, they have to say it for 2 years. So now phase 1 placebo group, because of ethical considerations, they switched over to 0.05. And what they found after 1 year was that children who were switched from placebo to atropine 0.05 also worked well. So far, so good. As I said, phase 2 was what was, bulk of us, most of us studied phase 2. And typically we thought that now we know a lot about atropine, and now by 2000, I think by this was the year 2020, 2021, when there were, as I remember, there were 4 companies in the market giving atropine, and main were obviously the Antod and Sun Pharma. Now, after this LAMP 2, if you go back, they actually published LAMP 3, phase 3 report. And in phase 3, they continued low concentration atropine for 3 years. During the third year, and to be honest, when we reported, we were one of the first in the country to report. When we reported our findings way back in 2018, we reported it for 3 years. We never did the study for 2 years. This 2 year thing came from Atom 1 and Atom 2. Now, how did this 2 year come into the picture? Now, when Atom 1 was done, they were doing a randomized control trial between the two eyes. So obviously, at the end of 2 years, they realized that they had already created an isometropia. So they said that you have to do it for 2 years only. So when they did Atom 2 study, that was also done for 2 years. But if you see Atom 2 study, there were a lot of patients who had rebound and were continued for 3 years. And now if you go to see, this is what they said, that LAMP 3 suggested that you can use it for 3 years. So that particular question, which normally we have, is that you can use it only for 2 years, is put to rest by a clinical study, by a published study in a good journal. And you see continued versus washout, efficacy with continued treatment was still very good. Rebound effect, yes, we will talk about rebound effect also. But if you go to LAMP 4, They actually extended it by another 2 years. So now they are talking about a constant treatment for 5 years, the continued atropine 0.05%. So now we have data published in 2024, last year, and there is a good work which said that most children needed to restart treatment after atropine cessation at year 3. Now atom 2 was stopped, bulk of it was stopped at after 2 years, and Atlas did not have patients, all the patients. Atlas only had a group of patients who came back to the clinic. So they were not representative population of all the patients, but yes, they had some of the patients where they had stopped the treatment at 2 years. So nowadays, what I do say is that you can continue atropine for a long time. So as you said, probably, as Dr. Minaj said, that probably the treatment was stopped little early. And if you stop the treatment early, especially in children who are like 8 years old, and you stop the treatment by 10 years old, they may hit the puberty at 12 or 11, and they may gradually go back to where they were. Now we come back to rebound. The question of rebound has not been answered by most of the studies, but there's a good body of work which now suggests that there were at least 3 papers which we discussed when I was talking in my video about how does atropine work, and they do suggest that although there is no gross change in lens thickness, at least some of the studies do suggest that there is a lens thickness change, very minimal, to the tune of 0.02 millimeter, and a follow-up study which was just published in 2025 suggests that there is actually a change in the lens position also. And that is also one of the reasons why rebound is higher with a higher concentration. Now, this is still a hypothesis because there was a follow-up study which suggested that this was not truly not 100% as it was suggested. So rebound is definitely there, not in all patients. It is there in a lot of the patients, more concentration, more rebound. But if you continue it for pretty long time, rebound is not more than 0.5 diopter, because that is what can be explained by the theories of change in lens thickness and change in effective lens position, or because of the accommodative effect that atropine has. That is what the change they suggest. So rebound can be there for half a diopter, but if you have continued atropine for pretty long, so I do suggest that you can obviously after 2 years you can take a call, but you may have to, as they also say, you may have to restart treatment after cessation at year 2 or year 3. So now that we have a very good evidence by LAMP 3 that you can continue the treatment for 3 years, stop continuing it for 2 years, rather continue it for 3 years. Unfortunately, phase 3 and phase 4 report were very not much publicized. So this thing has not come into the in common jargon that we can use it for 3 years. So it has to be used for 3 years, and then you have to take a call whether you want to restart or not. Yes, tapering also makes a difference. When you are stopping atropine, you can taper it gradually. And tapering also doesn't have a real, nobody knows how to taper. So some people, what they do is they start 0.01 alternate days, and then once or twice a week, and then they stop. So yes, tapering also reduces the rebound, but some rebound definitely occurs. So you can continue it for a longer time, and the rebound remains constant. Not that if you continue it for 3 years, the rebound will be higher. So rebound remains constant. I think does it answer your question, Minas?
Yes. Yes, sir. So I think it would be prudent to continue it for 3 years, especially in younger children, and
Yes.
then probably a PRN basis after that.
Yes. If at all it is like whether needed or not needed, you can, depending on that, you can, if you have to take a call whether you need to do it or not.
Thank you, sir.
So I have a question.
Sir, again, in younger children, 3 years might not be sufficient, sir.
No, 5 years, no. Now, so they have come up with 5 years already. See,
Okay.
that they're talking about over 5 years. What they are saying is that most children, what they did differently than Atom 2 was that they, instead of stopping at 2 years, they stopped at 3 years. And
Okay.
then they also restarted and continued till 5 years. But one good thing of Atlas is,
Still 5 years now. So it is safe to.
yes, that is what I was coming to. Exactly. That was the
Okay,
point
sir.
I was coming to. One thing which is good of Atlas study is that it is good that Minaz has pointed out. The good thing of Atlas study is that none of the patients had any side effects due to atropine, even after 10 or 12 years of or 15 years of follow-up. They continued it for 2 years, but there is always a concern. When you are using drops, you don't know that these particular drops at a younger age may lead to some problems when they grow up after 15 years or after 20 years. So some of the patients they had seen in 2006 and they followed them up in 2023. So almost, they had a difference of almost 15 years, 12 to 14 years, and they did not find any side effects of atropine, at least for 2 years, when they had used it for 2 years. So that's a good body of evidence that atropine doesn't have side effects, even long-term side effects.
So I have a question.
Yes, ma'am. Yes, ma'am.
So, so supposing we have been referred a patient who has a moderate myopia at a younger age, and he has been seen elsewhere where they have documented evidence of progression in the spherical equivalent, but the X length has not been measured there at the first visit. So when the patient comes to us, so in such high risk patients, would you want to intervene with the atropine, or you have to wait for 4 to 6 months and then get a X length measurement done?
See, I will like to. There are two things in this particular point. One is that it is very similar to glaucoma treatment. You have to find out whether there is a risk of progression or not, and if you feel that this particular patient definitely falls into a high risk category, you can go to use some calculators. All this is basically to be sure that we are doing something which will help the patient. So we can take parents into confidence. We can tell them that, this is the body of evidence which is there. And if we are waiting for 3-4 months, nothing is going to change. But if you feel that, this should be started because there's a good body of evidence that your child may progress. See, this is how we had convinced when we did our pre-myopia study. See, we have myopic patients, so they already have glasses. But pre-myopia, it was very difficult to convince patients, and that is why the sample size was very small. Because when you tell the patient that your child will have glasses, they always say that, where is the risk? So it was very difficult to convince them that, this is the body of evidence which shows that your kid will become myope. So if there is evidence, you can start. There is nothing wrong. But if you feel that, if you feel that there is not much of a risk, and probably the other person has not done cycloplegic refraction, and if you want to wait for 3-4 months, the number is not going to progress more than 0.5 diopters. Because needless to say that you will obviously talk about environmental modifications, you will already always talk about reduced near work. And we all know that, these 2-3 things they also go a long way in slowing down the myopic progression.
Yes, sir. So another point is that, like you have shown in your video, that you have used it for pediatric cataract patients also who had a
Yes.
myopic shift. Does atropine work? What was your experience like? Because myopic shift in pediatric cataract, post-pediatric cataract has a different mechanism to explain. Like they said, because most of the times it's an amblyogenic factor which causes a myopic shift in these patients,
No,
especially the unilateral patients. We see much more myopic shift. So does atropine will work in
no,
those
no.
cases?
There are 2-3 things when we talk about pediatric cataract myopic shift. It is not just the amblyopia. Even if you have a patient who has good vision, he may still progress, because I understand that not we all these patients, they were not really unilateral cataracts. There were 2 patients who were unilateral cataracts, but there were 5 patients who were actually having bilateral cataracts. So unilateral cataracts do progress because of amblyogenic factors. That is perfect. But there are patients who have good vision and yet they progress. Some of them, like even traumatic cataracts, sometimes you operate them, they have good vision. And once you see them after 2 years, they become myopic. So yes, they do have different mechanism of action, but at least in our patients, we did use atropine, and we did not use them before 4 years. I think the youngest was 4 years only, because we did not want to go into that cascade of less than 4 years having a different mechanism of action or having a physiological growth of eye. So we did not wanted to interfere there, and already we had left these patients hypermetropic. So if we go very early, there was a chance that these particular patients will end up being hypermetropic only. So most of these patients, once they started going towards going towards myopia, or once we had a decent record that they are gradually progressing, only then we sort of intervened. So if you see this chart also, like if you see any random patient, say this particular patient, he has an axial length of 22.91, went to 23, went to 24, and we only intervened at 24.61 because there was a good body of evidence that he's losing out his refraction very quickly. All of these patients were actually hypermetropic. When they were left, they were hypermetropic.
So, but how much reduction did you get? Like, was there any difference in these pseudophakic patients versus the normal patients when you put them on atropine?
No, the sample size was very small. To be comparing with normal patients, the sample size was hardly 12 eyes. So the number of eyes are too small to be compared vis-a-vis a normal school-going myopia, because the number is very small. Pediatric cataract patients itself is small, and then to have have an axial length of these patients coming for follow-up, very small. But if you see, what we did was we actually started calculating their pre-atropine absolute growth and rate of axial growth, and post atropine absolute growth and rate of axial growth. Now, this particular thing is very much skewed, mainly because these children were very young when they were operated, and so this particular 5.15 is not really the myopia which we see in actual patients. This is basically the physiological growth that occurs to match up the emetropia. So this is in less than, this was 2 years of age, 4 years. This is 2 to 3, 2 to 4 years of age. The eyeball is growing. Why? Because eyeball has to grow at that particular age. So the first spurt of growth will occur between 0 to 1 year. The second spurt of growth will occur between 1 to 3 years. So that is what I'm saying, that this particular thing only tells that the rate of axial length growth was reduced. But this particular thing doesn't give you a true picture that it was atropine which reduced this. The age, once the age is above 3 or 4 years, all these myopic patients tend to stabilize. And so what we do in our undercorrection pattern is that we are very aggressive when we are operating less than 1 year. We are less aggressive when we operate between 1 to 3 years, and above 3 years, we are not very aggressive when it comes to undercorrection. We are only aggressive above 3 years in pediatric cataract when the axial length is more than 24. Otherwise, we are not very aggressive in undercorrecting. So we don't really use Inyardi's formula when the patient is 4 years. We may not undercorrect 3 diopters if the axial length is only 21, because he will not grow so much after 4 years of age, given that his axial length at 4 years is only 21 or 20.5. So he is not going to grow as much. Whereas a child who is at 4 years has an axial length of 24.5 is already myope.
So I'm asking this because I had a paper during my fellowship for pediatric cataract myopic shift, and what I found, like, it was a 40 eyes sample size, and there was a myopic shift which was much more seen if the patient was operated at an early age or it was a unilateral cataract. And how much was the myopic shift was very difficult to actually find out. So such in such patients, is it good if we extrapolate and start intervening with atropine? Because we know there is going to be a myopic shift, but how to balance with the emetropization at the same time? It's like,
So there are three factors there. One factor is so we had a paper in 2016 where we started telling that, normally when we undercorrect for pediatric cataracts, what we do is we undercorrect based on the fact about what is the age. So anybody who is undercorrecting for pediatric cataract undercorrects only on the base of age. There is no other factor that is under consideration, right? So whenever you are undercorrecting, what is your factor? Whether you go by Arvind formula, whether you go by Dr. Rupal Trivedi's formula, or whether you go by this NID's rule, or whether you go by percentage reduction of Dahan et al. So all these things are purely based on age. If we take a simplified version of that, you can take Inyadi's formula. That is the most easy way to understand. So what does that say? You have to subtract the age from 7 and do undercorrection accordingly. Now there is a basic flaw there, because the only thing that we are doing here is taking age into consideration, whereas eyeball is completely different for different patients. Some patients, and they may argue that these patients they have an axial length of 25 at the age of 4 years, mainly because they have a cataract. Once you remove the cataract, their axial growth will not be similar to what it is. And we tried to prove that one factor is definitely age. When you say that how to achieve immetropization in pediatric cataract, we have to take into consideration age. We have to take into consideration the axial length at presentation at the time you are operating. Both the things you have to take into consideration, and you have to find out what is the age at which you can intervene. In a very good paper by Dr. Vasavada and the co-author was Dr. Bharti Nehlani, they have published an article in AGO in 2004. Now, what they have said is that is the place from where I took this rate of axial growth. Now, what they said was that bulk of the growth, if you are operating under 1 year, you have to calculate extra, because the growth will occur very quickly in 1 year. If you are planning to implant an IOL under 1 year, between 1 to 3 years, the growth slows down, and between 3 to 8 years, it is almost very, very slow. So you have to take age into consideration, but you have to be very aggressive when the child is young. And in unilateral cataracts, normally I don't undercorrect more than 3 diopters, because once you undercorrect more than 3 diopters, for near you are still inducing an anisometropy of 6 diopter, because if the child looks for near, you have to add 2.5 to that. So it becomes very difficult for us to treat that child who has an anisometropy of almost 5.5. So for unilateral cataract, if the age is less than 2 years, still I will not undercorrect beyond beyond 3 diopters, because the anisometropia that I will induce will be much greater and much difficult to treat than to treat the actual immetropization. And these patients, once they are around 3.5 years and they have already eaten up the 3 diopters which you have given them, you can put them on atropine, because now you want to slow down their progression.
Right.
And atropine really works well. This is the data of 0.01%. Now we are using 0.05% in those kids, but that was only 1 year back, and we don't have the data for that. But atropine 0.01% we started using much earlier, and we were not really afraid, because we knew that there is not going to be any problem about accommodation and photophobia. So we did start using it twice a day when we found that 0.01% was not effective for once a day. But we did not use higher concentrations. 1 year back, we started 0.05%. It works well. It actually works well.
Okay, sir. Yeah. Thank you, sir. Sir, any experience with the ROP, the lasered ROP kids?
No. It's, I mean, that is the basic problem is that, we did present our findings there, but there was a paper from PGI by Dr. Katoch and Savlin. And what they had shown was that, it is basically the cornea which is related to that. We already had done our, we had done our normative for ROP. Did not publish it, but we have the data which suggests that if you, today itself I saw a patient, corneal curvature was 49. Once you see a kid, corneal curvature is more than 44, you just have to ask them whether the kid was premature or not. And most of them are. And if you see their ACD is less than 2.8. And their, the lens is also slightly pushed near. So it is basically the crowded anterior segment. And if you check their axial length, it is normally not more than 23, 24. So, it becomes very difficult to tell them what is to be done. And in my experience, I have seen ROP babies don't progress beyond that, the physiological cutoff as suggested by Dr. Vasavada for pediatric cataract. Means they don't progress much after 5 to 6 years. Very few children who do progress after 6 years of age, at least in our experience we saw. We don't have a data, so I will not say that this much numbers don't progress and the Smith numbers do progress. But I see that, all these ROP babies, because we do a lot of ROP work, all these ROP babies progress very quickly in first 2 years or first 3 years, and then they slow down, and then they remain high myop, very high myop, like -8, -7. And if you see their biometry profile, it becomes very difficult to have anything on axial length. So axial length is not much. So it is very difficult to give them a drop which is, helping them out with controlling the axial growth.
Yes, sir. So just the last part. So like when you measure the response to the treatment which you give these patients, like for spherical equivalent, we say it has to be less than 0.5 minus 0.5. And so what about the excellent growth? Like it's
Point
less
two.
than 0.2.
Point.
And so sometimes they don't coincide. Like you're getting a response in
They
the
never
spherical
coincide.
equivalent. Yeah.
They never coincide. So that is what, I will show you. There is a good article by these two articles. Surprisingly, if you see, these two articles were published back to back. Yeah, this is what I was saying. If you see this article, these two articles, this is by Dr. Saxena in 2023 June, and if you see, yeah, and this was almost similar article published just a month before. Both of them are very similar. If you see both the articles, what they are saying is that and these two articles do explain. So what they have done in this article is they have tried to calculate lens thickness. Now, if you see here, lens thickness change is not much. So I'm talking first about this Havid Hansen et al. Now, these three groups are: this is placebo, this is low dose atropine 0.01% for 2 years, and loading dose of 0.1% for 6 months, followed by 0.01% for 18 months. So these are the three groups. And if you see after 3 months, if you see the lens thickness change, after 3 months, there is hardly any lens thickness change. In the loading dose, you can see 0.03 millimeter. Similar change was also published by Saxena et al. 0.03 millimeter. Now, obviously, 0.03 millimeter, to say that it is significant is very difficult. So what they did was they calculated the lens power using the Bannett's formula. So lens thickness was measured by atom and lamp also. They did calculate, but they did not publish it, but because the thickness difference was very minimal. But if you calculate even with this small thickness, if you calculate the lens power, you will see that lens power difference was definitely significant as per them, only with 0.1% with Havid and Hansen. Although Rohit Saxena sir found that, with 0.01% also, they found that lens power difference was significant. Probably that is what explains that axial length change may not always correlate with this when we are putting atropine, because there are other physiological things which are also going on inside the eye, and that could be one of the reasons why axial length change does not properly correlate with axial length. Axial length change doesn't correlate with refraction. That is what was the point.
Right. Right. Thank you, sir. Thank you so much.
Dr. Jitendra, I
Yes,
have
ma'am.
one question.
Yes, ma'am.
Is atropine effective in unilateral myopia equally as bilateral myopia? And second question, in which cases you had to stop atropine? Like in which cases you had started and due to some reasons you had to stop atropine?
Mostly, when patient has any side effect, that is where we stop atropine. That has been very, very rare. There was a case series of 3 patients by Dr. Mihir from Mumbai, that was published in IGO, where they suggested that they had operated intermittent exo patients. Patients were already slightly myopic and they were on atropine. And post-op, they started developing esophoria and gradually converted to esotropia. And so in these patients, they stopped atropine. Fortunately for us, we never had such a issue. For unilateral versus bilateral myopia, I think it will work in both the cases. The only thing is that if the anisometropia is too large, like if one eye is at -3 and one eye is at -10, normally atropine doesn't really work because as we were discussing, as Dr. Reena Gupta said, that the myopia progression in a -10i is occurring mainly because of amblyopia, and amblyogenic risk factor is the major reason for driving the growth. So
Okay.
it would be difficult to control that. There is not much work. There is a Indian study where they have used atropine for high myopes, and they have suggested that it does work for high myope. Although most of the studies which are published, they do not suggest that you can use it for high myopes, or they do make a difference in high myopes. But there is a published study in IGO. I think I don't perfectly remember, but I think it is from AIIMS Rishikesh, but I don't remember it. It was published 2 years back. They had used it in high myopes.
Okay. Okay. Thank you.
Thank you, ma'am.
Sir, are there any absolute contraindications for atropine, for using atropine? Are there any conditions where you never start the patient on atropine, something like that we should be aware of?
Maybe if there is a angle closure glaucoma and pupil dilates, but in kids normally, you won't see a angle closure. It is extremely rare, and normally atropine has not been used in any other if the kid has any other comorbidity. So nobody has actually
Sir,
used
what if the child has some
glaucoma.
neurological issues, like history of seizure or some other neurological issues? And if the child has myopia and it's progressing, are we justified in
No,
starting atropine?
See, in those patients, there are 2, 3 issues. Like as a not as a as a myopia specialist, but we have to understand that compliance is the major issue in atropine. Parents are dealing with too many things when it comes to developmentally delayed kids. The the as Dr. Reena said, that the mechanism of action or the reason why myopia is progressing may have a separate arm, and so it is always better to give them glasses. And normally these patients who have high myopia, like Down syndrome patient, their myopia progression has a separate route of action, and so atropine has not been tried, and atropine may not work in those patients. So if you have a syndromic myopia, if you know that there are if it's a Stickler syndrome, or like we already discussed, ROP or Down syndrome, I don't think atropine will work. So it has been used mainly for school-going myopia, straightforward cases. It has not really been used in developmentally delayed kids, because they won't come back to you saying that they are not able to see for near, number one. And it has also been reported that children with developmental delay or with cerebral palsy patients also have problems of accommodation, similar to what Down syndrome children also have. So I don't think that we are really justified in using atropine. We can ask them to reduce their near work, but they won't do that, because they cannot go out and play. So they have to sit indoors, and that is also one of the reasons why their myopia does progress. So I would be going for a more safe thing, to talk with patients, talk with parents, and tell them to use even myopia control glasses. But you have to do it individually. Like, you have to see each patient and what he is doing to really justify using atropine.
Thank you, sir.
Ramya had a question.
No, sir.
Acha, okay. No problem.
Sir, in one of the article, it was like the adults did not show any change to atropine. So till what age the last we can consider starting atropine to the patient?
See, if the axial length growth is occurring, so I have used till 21 years also, but those are only 2 patients. And after, I think, 16 years of age, though I have children who are putting atropine, but after 16 years of age, they start saying that there is some blurring for near. So after 18, definitely, patients do have significant problems for near. And if they don't have, and if they are progressing, you can continue atropine. one of the reasons why you should have you can always use a combination therapy or tell them to use myopia controlled glasses is that, you can use atropine for a couple of years, like 5 years, and then gradually taper it. Start with myopia controlled glasses at that point of time, maybe. So because, you have been using atropine, myopia was controlled, you used it for 5 years. Now you can switch over to either combination therapy if there is a progression, or if it is time that you want to stop atropine and you want to go for alternate therapy. But you can use it till 18 years of age.
And sir, as we were discussing on the group, like we can increase the dose of atropine to BD also.
Yes.
So in what specific conditions we can go for BD dosage and
If you start atropine once a day and you are waiting for 3 months, you are waiting for 4 or 5 months, and if the progression is still there by more than 0.2 millimeters, or if the glass power has increased by more than 0.25 or 0.5, you are justified in increasing the dosage to 2 times a day. Because if it is not showing any effect, if you are using atropine and if still the progression is there, in non-responders, you can use twice a day.
okay, sir. Thank you, sir.
In which cases you decide to increase the dose or give some glasses, peripheral defocus glasses?
There are two things in that, madam. If patient is, if patient is affording, it is always better to keep it once a day. Because honestly speaking, being a father of a myopic child, it is difficult to remember to put drops every day once, forget twice. So once you have combination therapy, let us keep it once a day and switch over to combination therapy if patient is able to afford. If
And
not,
when will you start both together from day one?
you can start it from day one also. If it is all about, so if the patient is affordable and if you want to start from day one itself, if the progression is not much, why not start only glasses, wait for 6 months, and if he is still progressing, you can always add atropine. Because honestly speaking, madam, atropine works very well. The compliance is not there. It is like glaucoma. You have to put it almost every day for 3 4 years, which is a huge task.
Right. So if patient is affording, your first preference is glasses, right?
Glasses,
And
because
if
compliance is
not
good.
affording, then atropine.
Yes.
Okay. Thank you.
And sometimes, if they are very fast progressors, like if they have come to you, you have seen the patient has progressed by 0.75 in 6 months. Then you have to start both the things and you have to tell them that environmental modification is a must because they are doing something which is leading to such a strong progression.
Okay. Okay.
Sir, is there a role of atropine in myopia that is associated with ocular albinism?
Honestly speaking, madam, there is not much work done on all these things because the moment they start atropine, the first exclusion criteria is any syndromes associated with eye, they will not use atropine because it is not understood how atropine is working and they don't know why myopia is progressing in a particular child. It doesn't have huge side effects. So off the record, yes, in couple of patients, you can use it. Take the patient in confidence, talk with the patient that, this may help, this may not help. You can always start it and see whether it is working for that particular patient or not.
Okay, sir. Thank you.
Dr. Kalyan?
Yes, sir. This was just an additional question to the last question was asked. When do you switch to twice a day dosage? Rather than that, do we switch instead of changing the dosage? Do you switch to the concentration?
No, I don't switch to the concentration first. But there are two reasons for that. One, it is not available in the market.
Yeah.
So right now, 0.05%
Now,
is
since it is available.
No, it will be available from next month, sir. It is not.
Yeah, that is right.
Yeah. So at this point of time, the problem is that I get only 200 vials every 3 months. So I have to use them judiciously on the patients who are on trial. So atropine 0.01%, if you do it twice a day, it does work at least in 1/3 of the patients. So you are at least in those patients, you don't have to, put them on 0.05. If it is working twice a day and patient has progression has stopped, then you don't want to switch over to 0.05. At least those 1/3 patients are happy with 0.01% twice a day. And also because 0.05, if you start, at least in our work, we saw that almost 8 to 10%. So 8 patients out of 100 do complain of problems for near work and photophobia. So the chances of those side effects are definitely more when you increase the concentration to 0.05.
Yeah, sir. And about the rebound, uh, logically, it feels that the age at which the child completes its 5 years of atropine, if it falls somewhere between, say, the child starts the treatment at around age 6, or vis-a-vis the child starts treatment at the age of 8, and it is one who has crossed puberty and one is about to go puberty, will the rebound be definitely more, and we might have to taper off or maybe maintenance
Yes,
in spite of 5 years after completing 5 years?
Even after 5 years, the rebound will remain the same, sir.
No matter at what age he completes the treatment.
Because the rebound is constant, but rebound is also accelerated by the fact that he is at the age of puberty. The example in which you have given.
That was the question, sir.
He is already growing at that age. So once he is growing at that age, obviously his rebound is not true rebound. His rebound is also with his actual axial growth.
Yeah, so we have to continue further then.
You can introduce the alternate therapy also, sir.
Yeah, yes.
After 3-4 years, children who have put atropine for 3-4 years, they know that, you are working for them. Initially, they do have this idea that, atropine will work or not. They have a lot of doubts that, you are putting a drop for myopia, which is not really going to work. So once they use it for a couple of years, now they know that, if you are talking about defocus glasses, you are actually trying to, it's not about selling them costly glasses, but it is actually that you are on their side. So they do agree after a couple of years, they do understand the whole thing.
Yeah, it's so very similar to glaucoma.
Yes, absolutely. Yeah. I keep telling in most of my lectures that, it is so similar to glaucoma. You have to find out the evidence whether it is progressing or not. Glaucoma also, you have to find the evidence that it's progressing or not. It is also a compliance-based solution that you are giving. That is also a compliance-based solution you are giving. If you have a different mechanism of action like 7-methyl xanthine, you should give it because it will be acting on some other pathway. This is acting on some other pathway. So combination will always be better. It's very, very close to what we have in glaucoma.
Yes, sir. Thank you, sir.
Sir, I have a question related to combining atropine with orthokeratology. Any comments on that? Because both of them are to be administered night time. So won't it be difficult for the patient or anything on ocular surface?
No. Atropine, I mean, there have been a lot of work on atropine with orthokeratology, not from India, mainly because orthokeratology was never, it's not really popular in India, obviously because of the cost. The cost of orthokeratology is huge compared to atropine or even glasses. And orthokeratology at the end of the day is working on the same principle of peripheral defocus. So the only advantage of orthokeratology over glasses or over atropine is that they don't have to wear glasses throughout the day. And the problem with orthokeratology, the other side of orthokeratology is that they have to use the lens every night. So it is almost same. Now coming to the point that they have to use it at the bedtime, whether atropine can be used bedtime with orthokeratology. Once you put atropine and once you have waited for 5 to 10 minutes, then it is already either absorbed or removed through tears. So there is nothing really active on the surface. Either it has gone inside or it has come outside. So I think orthokeratology, the lens can easily be used, and it has been used. A lot of people who have, who have worked on orthokeratology with atropine. Multiple studies are there. That will be covered in chapter 6. But yes, that is definitely something which once orthokeratology becomes popular, or I would say once orthokeratology becomes affordable, it would come up definitely. Because right now, combination therapy in India means atropine with glasses. There is no MiSight lenses. There are no orthokeratology. There is no red light, repeated red light therapy, low level red light therapy. The only two current treatment modalities are glasses and atropine. So, bulk of the combination therapy also works around that, at least in this part of the world.
Thank you, sir.
Sir, just a theoretical question. Given the fact that atropine works on the structures like sclera, choroid, and RPE, the proposed mechanisms are that. Are there any alternative delivery systems being evolved? Because 0.01% concentration achieving sufficient ocular concentration to have a substantial effect. So, any depot solutions or anything that is in pipeline?
So there are two answers to this. One is that I wanted to include that particular paper also, and I was waiting to get the full text. I had called him up, but could not include that particular paper. There's a paper by Dr. Rohit Saxena where what they did was they put atropine and they tried to find out whether atropine reached sufficiently inside the eye, and they could publish that there is sufficient amount of atropine which reaches inside the eye, so with the drops. Now coming to alternate delivery system, yes, there is some work on contact lens based solutions, but the problem is all these things are very much possible with glaucoma because it is a disease of adult, and here we are talking about a disease of kids. So nothing much has been they have used some atropine soaked this things, but they have not come up with any concrete this thing, not really something that they can put a OcuCert or some device like that which can release the sustained dose, because yet we are not able to find out what is the sustained dose. It's not like glaucoma where we have a good idea that we don't want any ups and downs. Here we have absolutely, we don't have huge knowledge as to how much should be going, and if it is kept in conjunctiva, obviously the absorption will be better. But at this point of time, they have suggested that atropine does reach in sufficient quantities inside the eye, at least in aqueous humor.
Okay, okay. Thanks.
Yeah, I think we have. So if there are no questions, we will close this meeting. The next will be on, there will be two parts of next video. One will be on peripheral defocus, a small part, and the rest will be on why peripheral defocus and how peripheral defocus has to be used for glasses and how it has evolved, and what are the glasses which are available, and what are the newer glasses like dots and everything from Essilor, and how they are effective. So I think next week we will be uploading that video.